Hello everyone, I am Dr. Danish. I am doing postgraduate diploma in endocrinology at South Wales University, UK. The topic of my discussion is a fine needle aspiration cytology. I would like to start with the introduction of fine needle aspiration cytology. It is a very important technique in the evaluation of thyroid nodules, which are very common in the clinical practice these days. It involves taking a small amount of fluid or tissue from the thyroid gland with the help of a very small needle. It is widely available, well tolerated and low risk procedure. In this slide we can see the thyroid gland, which is a butterfly shaped structure. It is placed in front of the trachea, and at the top to the thyroid gland there is a larynx. We can see 4 yellow small parathyroid glands which are placed superiorly and inferiorly. In this slide, let's take a look of more structures which are related to thyroid gland. These are thyroid cartilage, cricoid cartilage. These two cartilages are placed in superior relation to the thyroid gland. Thyroid gland has 2 lobes which are connected with the help of isthmus. You can see in this slide this needle which is going into the tumor of the thyroid gland. It is performed in an outpatient department, so long hospital stay is not required. Local anesthesia is often not required as the needle is very thin, but it is advisable to use it as it minimizes pain. The procedure takes 20 to 30 minutes only. It has a sensitivity of 83% and it is 92% specific. Indications: presence of thyroid nodules, and if it changes dramatically in consistency and if it is causing hoarseness, so it is one of the indication. In addition, autoimmune diseases such as Graves' disease and Hashimoto's disease. Age and sex of the patient is also very important, as in the third point you can see if a patient age is 50 years and if he has rapidly growing tumor, so FNAC is done to rule out anaplastic carcinoma and lymphoma. Furthermore, fixation of nodule to the surrounding tissues, involvement of cervical lymph node, or if a patient gives a history of radiation exposure, and if there is a family history of Carney's complex, multiple polyposis coli and Werner's syndrome. Ultrasound guided FNAC is the most preferred method and it is used in the following patients: having non-palpable nodule, predominantly cystic, sometimes small nodules if they are located very close to the blood vessels. Every process has advantages and disadvantages. So the advantages of FNAC include it has a better patient compliance. Its performance has significant role in saving unnecessary thyroidectomies and equally minimize anxiety of the patient and physician. It helps in giving details about malignant nodules, benign ones or goiter, which can be treated pharmacologically. Cysts are aspirated with good results and it is economical. This procedure requires some equipments which are as follow: syringe holder, plastic disposable syringe, 25 to 27 gauge needles 1.5 inches long, glass slides, alcohol sponges, gloves, containers for cystic fluid collection, laboratory slip with patient's full details, 1 to 2 ml 1 to 2% lidocaine local anesthetic. Now you can see the pictures of all equipments which I have already taken name. Patient's position. The patient's position is important. The most important position is supine, which is mostly preferred. We put the patient in a supine position and place their neck in hyperextended way. Pillow is placed under the shoulders for support. Patient is not allowed to talk, swallow, or move the neck. We need to take the written consent from the patient, explain full procedure in a patient-friendly language, and take care of all precautions. If it is supported already by ultrasound, then palpatory method is used to do FNAC and the tissue is biopsied from the thyroid gland. We can see in these pictures how the patient is placed during the procedure, how we need to assemble the syringe and the holder, how we need to stabilize the nodule with the help of 2 fingers, and how we are putting the needle inside the nodule. Method. The physician should stand to the contralateral side of the lesion. The nodule is identified and cleansed with alcohol. The local anesthesia is needed to prevent pain using ultrasound FNA. A 10 ml plastic syringe is used and attached to the holder. 2 fingers hold the nodule and the other 2 hold the syringe, as we have seen in the last slide. Needle is either placed at perpendicular position to the probe or parallel. It depends on the patient's preference and expertise as well. Once the needle is inside the nodule, suction of 2 to 3 ml is applied with 6 to 7 to and fro movements over 5 to 10 seconds, and tissue is sampled. It is advised to avoid negative pressure as it can cause microscopic hemorrhages and it may impair the results of cytology, and we need to maintain capillary sampling method. According to some literature, suction and negative pressure is recommended to obtain the sample. A specimen is obtained from different quadrants of thyroid nodule. Once sample, fill the needle hub, withdraw the needle. We can see this thing in this small picture. Patient may have pain or dizziness after procedure, but they are allowed back to normal activities within an hour. Complications. There are some complications, some are rare and some are common. Among them, the rare ones are hemorrhages. Hemorrhages can cause acute breathing problems. Sometimes swelling can occur, ecchymosis, infection, dysphagia, hoarseness, sometimes temporarily increased thyroid function hormones. Contraindications. There is no absolute contraindications, but according to some literature, altered mental status, dementia, or communication problems, patients should stop anticoagulants and antiplatelets 5 days before the procedure. In some cases, if a patient gives a history of renal disease, liver cirrhosis, and any coagulation cascade disorders, it is advisable to stop anticoagulants 2 days before the procedure. Once the procedure is over, then we need to start the anticoagulant drugs within 12 hours. The physician should verify the bleeding risk. History is very important as well. Let's talk about the parameters which can minimize the post-procedural risk. These are 2. The INR should be less than 1.5. Platelets count should be more than 100,000. Results. The results are based according to Bethesda system classification, and they are divided into 6 categories. Category 1. If fine needle aspiration results are unsatisfactory, then biopsy is repeated so that diagnostic information can be revealed. Category 2 are benign lesions, which can safely be followed with the early ultrasound examination with the repeat FNAC with any increase in size or development of concerning sonographic features. The category 3 includes the intermediate group, which is subclassified into follicular lesion of undetermined significance, FLUS, follicular neoplasm, or suspicious for malignancy. The FLUS samples are sent for repeat as the malignancy risk is 5 to 10%. It is also proved by American Thyroid Association. Category 4 includes follicular neoplasm, or if it is suspicious for follicular neoplasm. Category 5 is suspicious for malignancy. The last category is category 6, which is a malignant lesion. It is identified by FNAC. It is an indication for total thyroidectomy. Ultrasonography should assess central or lateral nodal involvement. Furthermore, if the FLUS sample shows BRAF and positive for RAS mutation, then according to the research in over 900 cases at University of Pittsburgh Medical, total thyroidectomy is indicated. So these results, I'm repeating, is based on Batista's classification system, and they are divided into 6 categories. Similar to other procedures, fine needle aspiration cytology has pitfalls as well. There are chances of false negative rates or positive rates. The positive rates vary from 0% to 8%. It means the patient has malignant lesion, but it shows benign features on histology. The percentage of false negative ranges from 1.5 to 11.5%. The false negative rate is the one in which patient has benign cytology and later on thyroidectomy proved to be malignant. False results occur due to sampling errors. The most common cause of false positive result is Hashimoto thyroiditis. In addition, if the nodule is very small, such as less than 1 cm or too large, more than 4 cm, then there is a high chance of false negative rates. Sampling should be obtained from multiple sites rather than the only single point. It will make the results more pure. The absence of malignant cells in FNAC doesn't exclude malignancy, as sometimes even benign lesion has 2 to 3% chance that they can be malignant. Finally, I would like to thank all literature websites, especially EndoBible, Endocrine Society, EndoText and NCBI literature, which helped me in making my presentation very informative. Thank you so much once again.